This is Michelle Broussard presenting Group 3's meningitis case study. Our first patient is Terrence Richards. He is an elderly man who has hypertension and type 2 diabetes, which makes him a high-risk case. His niece says that as he's gotten older, his health and memory have been declining, but lately he has been especially confused. In addition, he reports a history of fever, headache, and neck pain. And another important thing to note is that he lives on a farm where he grows his own food and has goats and cows. He had a lumbar puncture performed to test his CSF. Here is his CSF report. The sample was cloudy and turbid, which means it contains an abnormal amount of white blood cells. We also tested the sample in a spectrophotometer to get an absorbance reading. The higher the concentration of the white blood cells, the higher the absorbance. A normal absorbance value for CSF should be close to 0. Here we also created a table comparing Terrence's CSF values with normal CSF results. This is what we found. His leukocyte cell count per millimeter cubed is 1,145, which is significantly higher than the normal range of 0 to 8. 70% of those white blood cells are neutrophils, also significantly higher than the normal 0%. His glucose levels are low at 20 milligrams per deciliter, and his protein levels are high at 410 milligrams per deciliter. From my research, I know that bacterial meningitis is characterized by elevated white blood cell counts between 100 and 5,000 cells per millimeter cubed, with at least 80% of them being neutrophils, also decreased glucose and elevated protein. Although Terrence's neutrophils are only at 70% instead of 80 and above, I am very confident that he presents bacterial meningitis. But before we can make a full diagnosis, I need to run a few more tests. So here's an overview of the tests we ran to help us determine if we are headed in the right direction of bacterial meningitis. I will talk about each of these tests more in the next few slides. The first test we ran was a gram stain. We did this test using a sample directly from the liquid culture of the CSF. When we reviewed our sample under a microscope, we could see that it was gram-positive, which means that we could rule out all gram-negative bacteria. So now we are left with the possibilities of Streptococcus pneumoniae, Streptococcus agalactiae, Listeria monocytogenes, and Mycobacterium. I also want to note that this slide says our pathogen is also bacillus-shaped, but we couldn't really tell from the gram stain right away, which is why we're keeping both Streptococcus bacteria in the running for now. Next, we inoculated different agar plates. We used chocolate agar, blood agar, and Thayer-Martin. Thayer-Martin only grows Neisseria bacteria, so no growth means that we can rule out Neisseria meningitidis. I also wanted to note that with our gram-positive staining results, we were already able to rule out Neisseria because it is gram-negative, but we did this test to confirm. Then we inoculated the blood agar on one side with patient 23's sample, and after the incubation period, we had colonies that were shiny and light gray in color, but the blood agar did grow less colonies than the chocolate agar. So the characteristics of the chocolate agar were the same as the blood agar, but because it is more nutrient rich, this one had more growth. And then we used our solid growth that we got for the next test, which was an acid-fast stain. We ran this test because an acid-fast stain will let us know whether or not our pathogen is Mycobacterium. And because our stain came out blue, we know we can eliminate it. If it had stained pink, Mycobacterium would have been our pathogen. So to recap, so far we have been able to eliminate all gram-negative bacteria through our gram stain, including Neisseria, which we confirmed with no growth on the Thayer-Martin agar. And now that we have ruled out Mycobacterium with this negative acid-fast stain. This means our remaining possibilities are Streptococcus pneumoniae, Streptococcus agalactiae, and Listeria monocytogenes. But to differentiate between these, we need to do one last test, which is a catalase test. So this helped us to rule out both strep bacteria because they are catalase negative, and as you can see from the results, our unknown bacteria is definitely catalase positive, indicated by the bubbles. So now we are able to eliminate both strep bacteria, and I'm confident that our unknown pathogen is Listeria monocytogenes. So Listeria is a gram-positive bacillus bacterium, which is non-acid fast and catalase positive, all which support our findings. It definitely makes sense that this is what infected our patient because from his farm lifestyle, it could have been easily caught through drinking his cow or goat's unpasteurized milk or eating unwashed vegetables from his crops. It's even more likely because he's an elderly man with hypertension and diabetes, so he already has a compromised immune system. For most patients, the prognosis for Listeria is good. However, the prognosis declines with the risk factors, like in Terrence's case, old age, hypertension, and diabetes. And in those cases, the fatality rate is about 20%. So for his treatment, he will need immediate IV ampicillin, which is a common choice for Listeria treatment. Then we will need to find an infectious disease specialist to help treat him with the appropriate antibiotics for the rest of the treatment. And he will need antibiotic therapy for about 6 weeks to fully recover. Some recommendations for him are to thoroughly wash and cook his food, wash his hands frequently, especially after handling his animals and crops, separate raw meat and vegetables from cooked meat and vegetables, avoid unpasteurized milk and other dairy products. And for him, there is no need to isolate. Hopefully with the antibiotic therapy, Terrence can make a full recovery. However, because he is elderly and immunocompromised, there is a greater chance that he may die from the infection. Now we'll move on to our second case, a 2-year-old female named Candace, who has been having a worsening headache for 4 days, and her mom says over-the-counter medications have had no effect. She also has a rash on her trunk, photosensitivity, a stiff neck, and vesicular lesions on her hands and feet. A lumbar puncture was performed to get a CSF sample for analysis. And these are the results. Cloudy but less turbid than our last patient's, with an absorbance reading of 0.061. Again, the absorbance gives us a quantitative value to the turbidity. Her leukocytes are elevated at 115 cells compared to the normal 0 to 8. The white blood cells are 30% neutrophils, whereas normal is 0 neutrophils. Her glucose is normal, and her protein is slightly elevated. From my research, I know that viral meningitis is characterized by 10 to 300 leukocytes per millimeter cubed, and there's usually a moderate level of neutrophils during the early stages. Glucose levels are normal, and protein tends to be normal but may be slightly elevated. By comparing my results and research, I am very confident that Candace is presenting viral meningitis, but before we can make a full diagnosis, we need to run a few more tests. We did a gram stain, inoculated chocolate, blood, and Thayer-Martin agar, and performed an indirect ELISA. Although we suspect viral meningitis, we still made gram stains from the liquid culture. It was no surprise that we had no gram staining results. We also made streak plates from the CSF sample and also, unsurprisingly, had no growth, which further confirms our suspicion for viral meningitis. And because we know we are dealing with viral meningitis, the final test we ran was an indirect ELISA. We tested a few different viral diseases, and each came back with negative antibody results except echovirus, which came back with a positive IgM. So what do these results mean? A negative IgG means that Candace's body has never seen this echovirus before, so there are no memory antibodies ready to attack the virus. And positive IgM means that our patient is currently infected with the echovirus, and her immune system is starting to fight off the infection. IgM is present the first time your body is seeing the infection, so either you're currently infected or you've been recently vaccinated. And since there's no vaccination for echovirus, then we know that Candace is currently infected. So echovirus is a non-polio enterovirus, which is the main cause of viral meningitis. The only way to become infected with an echovirus is by coming into contact with infected fecal matter, secretions, and surfaces. And in addition to the positive IgM results, the symptoms of echovirus correspond to the symptoms that Candace is presenting, so echovirus is the final diagnosis. The prognosis for Candace is good, and as for treatment, there is no specific or effective treatment available. Like most viruses, you can only treat the symptoms while your immune system fights off the infection. Echovirus usually go away after a few days without treatment. However, more severe infections may last a week or longer. So Candace should fully recover within a few days without any problems, unless it becomes more severe. My recommendations for her are that the patient should stay home and isolate while being carefully taken care of by her family. Because she's only 2, her parents will need to take care of her, unfortunately risking getting sick themselves. They should keep her hands and environment clean, and no specific preventative measures are available for future echovirus infections. And here are all of our citations.